Hi, this is Andrea Kane, and I'm here with you for HIT 292 Reimbursement Methodologies. And we are on Chapter 5 in our book, Medicare Hospital Acute Inpatient System. And let's take a look at what we'll be studying this week, which is week 3. We want to describe the structure of the Medicare Hospital Acute Inpatient Payment System. We want to illustrate the MSDRG assignment process, describe severity of illness levels of MSDRGs, describe the Medicare Hospital Acute Inpatient System provisions, and articulate Medicare value-based purchasing programs related to the hospital acute inpatient setting. So let's look at basic payment system concepts. The annual maintenance of Medicare payment systems occurs through the Federal Register. Make sure that you note that. The Federal Register is where you go to see what the annual rule will be. They do a notice of proposed rulemaking, then they have the proposed rule, they give a comment period, and then the final rule is published. And typically the final rule comes out 4 to 6 weeks before the Medicare fiscal year begins. And that always happens October 1st. The fiscal year for Medicare is October 1st through September 30th. So usually end of August, beginning of September, at the very latest mid-September is when the final rule is published in the Federal Register. So it's important to know that and important to be able to go there and read the information. Now, grant you, the final rule is an awful lot of legalese, but there are plenty of consulting companies and other organizations that distill that final rule out so that it's more understandable. Medicare cost reports are required on an annual basis from provider institutions, which include hospitals, skilled nursing facilities, renal facilities, like outpatient dialysis and organizations, hospice, home health agencies, health clinics, community mental health centers, and federally qualified health centers. Physicians do not have to, individual physicians or physician practices do not have to file Medicare cost reports, nor do ambulatory surgery centers. They're the two exclusions from that. The submitted data for the Medicare cost report includes facility characteristics, utilization data, cost and charges by cost center, Medicare settlement data, and financial statement data. And it is absolutely critical to get this Medicare cost report absolutely as accurate as possible before it's submitted. It has to be filed within 5 months of the end of the organization's fiscal year. So if your organization's fiscal year ends December 31st, you have to have this submitted before the end of May. So it works off of your facility or organization's fiscal year, not the Medicare fiscal year. It gets submitted to the MAC, and it's maintained in the HCRIS system. The data is used by CMS and for research. When we look at the value-based purchasing concepts that have been utilized by Medicare, it really comes down to the goal of CMS to optimize health outcomes by improving clinical quality and transforming the health system. They want better care for individuals, better health for the population, and lower costs through improvements. Gee, what does that sound like? The triple aim? Yeah, it sure does. There are 6 goals of CMS's quality strategy, and they are all listed here for you on the screen. They include safer care by reducing harm, help the patient be partners in their care, promote communication and coordination of care, promote prevention and treatment of chronic disease, work to help people live healthier lives, and make care affordable. And it would be helpful for you to know those things. Value-based purchasing programs link quality to reimbursement. That's really the bottom line. They link that quality to reimbursement because they pay for reporting, pay for performance, and pay for value. The quality reporting program pay for reporting program is included for most Medicare payment systems, that aspect of it. CMS allows facilities to maintain full payment if they successfully participate in the program. When we're looking at the acute inpatient side of all of this, it includes case rate reimbursement methodology. Again, I told you the federal fiscal year is October 1st through September 30th. There are some exclusions. Inpatient psychiatric units, inpatient rehabilitation units, and inpatient long-term care units, or I'm sorry, not inpatient, but long-term care units, they are excluded from IPPS. And cancer centers, Alliance of Dedicated Cancer Centers are also IPPS exempt. Those are reimbursed via reasonable cost. But if they're not inpatient psych, inpatient rehab, or a long-term care, acute long-term care unit, then they have to do IPPS. IPPS uses Medicare Severity Diagnosis Related Groups, or MSDRGs, to determine payment, or reimbursement, I should say. They organize inpatient admissions into larger groups for reimbursement. They group like patients with like resource consumption and length of stay patterns together. So the relative weight represents the resource intensity of the group. Case mix is the complexity or description of the patient population, and case mix index, or CMI, is the weighted average of the sum of the relative weights of all patients during a specified time period. The system takes into consideration the role that a hospital's case mix plays, that should be plays, not plans, in influencing costs. MSDRGs were the first system to allow the measurement of a hospital's case mix complexity. Direct measure of the resource consumption and therefore cost of providing care was integrated, and a hospital with a complex case mix means that the hospital's patients are consuming more resources and therefore the cost of care is higher. A good example of this would be to compare your community hospital, wherever you're at, the closest community hospital, with like a University of Iowa, Iowa City, or a Mayo Clinic. Do you think that Iowa City and Mayo get more complex patients, or more sicker patients, harder to treat patients? Absolutely. And those patients consume more resources, have a longer length of stay, and the cost of their care is higher. So their case mix is going to be higher to reflect all of that. And the opposite is true as well, that a hospital with a very high complex case mix means that their patients are consuming more resources and their cost of care is higher and they need better reimbursement. And MSDRGs as a system allows most facilities, most acute care hospitals, to be reimbursed on this basis. MSDRGs is what's called a fully packaged system. Only one MSDRG is assigned per encounter, so one reimbursement amount is provided per admission. The reimbursement amount is intended to cover all facility costs, including pharmaceutical, supplies, and nursing. Now, it does not include the physician component, so watch out for that. MSDRGs do not include the physician component or the provider component, but the pharmaceutical, supplies, and nursing, that's all included. The facility accepts profit or loss. If you have a facility that is getting a patient with a particular MSDRG out within 3.5 days versus another facility that's getting patients out in 4.1 days, which one is risking more loss? It's the one with the longer length of stay. Because if you can safely get your patients out in 3.5 days, you need to do that. If you can't safely get them out in 3.5 days, if that's the average length of stay, then you really need to look at your documentation and the sickness of the patient and what's causing delays in that discharge. Is there a test or treatment not available? Is there a provider or consultant not available? Is there a delay in getting discharge orders to get the patient out? And so, the doctor, if he's not rounding, the hospitalist, let's say, if they're not rounding until 3 or 4 in the afternoon, and by the time they get discharge orders, it's too late to get the patient transferred to a nursing home. All of that plays into length of stay. And the longer the hospital keeps the patient, the less money they will make, and the higher the risk is that they will lose money. So this drives facilities to practice cost management. There are 25 what are called MDCs, major diagnostic categories. They are broken out into surgical MSDRGs and medical MSDRGs. And then within that, you have all of your MSDRGs. An MSDRG can include up to 25 diagnoses or up to 25 procedures or both. It looks at discharge status. So, for instance, if a patient dies, that makes a difference. If a patient is discharged to a long-term care or a skilled nursing facility, that makes a difference. If they're transferred to an acute care facility, let's say that a hospital has a patient, they've got something going on in terms of their cardiac, their heart, and they end up being transferred to a higher level of care for maybe open heart surgery or coronary artery bypass graft or a CABG. That discharge status is very significant. The sex of the patient and the age of the patient also often determine the MSDRG as well, or limit it. So there's a group number, an MDC assignment, major diagnostic category. Medical surgical status is in there. Title, length of stay. They have geometric length of stay as well as an average length of stay. And then relative weight. This is the measure of resource intensity for admissions in that MSDRG group. And the code range that drives that MSDRG assignment. So this is an example for us to look at, and of course this is in your book. This is MSDRG 293, and this is from fiscal year 2018, so it's 3 years old plus. The geometric mean length of stay is 2.3 days. The arithmetic mean length of stay or average length of stay is 2.8. What that means is that most places are getting these patients out in 2.3 to 2.8 days. The relative weight of this DRG, which happens to be heart failure and shock without complication or comorbidity or major complication or comorbidity, so that's without CC or MCC, is 0.6553, and it includes the principal diagnoses that are listed in the ICD-10 codes there underneath. There is a severity of illness component. The severity of illness refers to the extent of the physiological decompensation or organ system loss of function. MSDRGs use secondary conditions to establish severity of illness. This is where you get into your CCs or your MCCs. CCs mean complication or comorbidity. MCCs mean major complication or comorbidity. So you have what's called an MSDRG family. And within that family, you can have with CC or MCC and without CC or without MCC. You can also have with MCC, with CC, and without MCC or CC. So you can have all three. Just depends on how they're laid out. And this just reminds you that you go to the pre-MDC assignment, then you narrow it down to the MDC assignment, then you figure out is it surgical or medical, and then you refine it from there. So the first thing you do is pre-MDC assignment. There are 15 MSDRGs for which the MDC of the principal diagnosis is not taken into consideration. The cases are directly assigned based upon the principal procedure codes only. The resource intensity of the procedure drives the assignment for these cases. A good example is what they give you here, a mechanical vent. If a patient's on a vent for more than 96 hours, that drives the resource consumption and therefore the MSDRG assignment. So if you have a patient who's on a mechanical vent for more than 96 hours, it doesn't matter what their principal diagnosis is. They're going to be put into a specific MDC that has to do with mechanical vent for more than 96 hours. So that's one of those pre-MDC assignments that'll just take you right to where you need to go. So this gives you the example in your textbook that a pancreas transplant can be performed for a variety of clinical conditions. There are diagnoses that warrant a pancreas transplant that can be found in multiple MDCs, but there's only one MSDRG for all pancreas transplants regardless of principal diagnosis. Thus, the patient who receives a pancreas transplant is always going to be assigned to MSDRG 010 regardless of their principal diagnosis. So same thing with the mechanical vent. If you've got the procedure is what's going to drive you to your MSDRG. All right, in many cases. All right, so once you've determined that if you're doing pre-MDC assignment and your principal procedure, doesn't drive you into a specific MSDRG, then you're going to move on to step 2 here, which is MDC determination. And that is where you use the principal diagnosis to figure out which MDC you're going to be in. And the principal diagnosis definition, which hopefully you know from your classes with Shelley Grant, is established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. What bought the bed? That's what I've always done. If you're looking for your principal diagnosis, it's what bought that inpatient hospital bed. What was so significant that the patient had to be inpatient? That's going to help you. And don't forget, it's after study. Patient can come in with shortness of breath. They can come in and think it might be one thing, that maybe it's something to do with their lungs, but they find out it's actually something to do with the heart after study, but that's what caused the admission. So, example in your textbook, patient A presents and is treated for pneumonia caused by Streptococcus group A. Cases assigned to MDC-04, diseases and disorders of the respiratory system, because the pneumonia is what's driving it. It's that principal diagnosis. Step 3, medical surgical status determination. Was an OR procedure performed? And by this, they mean inpatient OR, not an outpatient procedure, but an inpatient operating room procedure. If it's yes, it's going to be a surgical status. If no, then it's always going to be a medical status. So they give you another example. Patient A presents, is treated for an acute myocardial infarction, also known as an AMI, of the anterolateral wall, initial episode heart attack. So you've got your MDC, which is 05, diseases and disorders of the circulatory system. The PTCA code is a valid OR procedure so that this case is a surgical case. But with patient B, they didn't perform any procedures. They didn't give any PTCA to break up that clot. In that case, it's going to be a medical case under MDC 05. And that will drive you to your DRG, because if it's a surgical case, there's only a certain number of DRGs that will fall under that MDC, versus medical case will have different MSDRGs under MDC. So they'll be in the same MDC, but which MSDRG they fall into will be determined by whether it's surgical or medical. So then you refine. From there you refine. Various questions are used to isolate the correct MSDRG assignment, because this is what allows the MSDRG system to group together like patients from the clinical perspective with like resource consumptions. So there can be one or more refinement questions in the pathway. So example, is there a major complication or comorbidity present? Is there a complication or a comorbidity present, or is there neither of the two? Did the patient have an acute AMI, heart failure or shock? Did the patient have a coma? Did the patient have a coma that lasted less than or greater than 1 hour? Was the procedure performed for neoplasm? What is the patient's sex? And what is the patient's discharge disposition? Were they alive? Were they expired? Were they transferred to another acute care facility? Did they go to a skilled nursing facility? All that matters. All right, so they give us another example that patient A is 67, admitted for a duodenal fistula closure procedure, falls into MDC 06, diseases and disorders of the digestive system. The fistula closure procedure is a valid OR procedure. Is there an MCC present? No. Is there a CC present? Yes. The patient had osteomyelitis of the vertebra, and so it met the CC criteria. So the MSDRG assignment for this case is going to be MSDRG 327, stomach, esophageal, and duodenal procedures with ACC. And they give you another example here. Patient B is 68 years old, admitted for cellulitis of the right ankle. It falls into MDC 09, diseases and disorders of the skin, subcutaneous tissue of breast. Non-excisional debridement is not a valid OR procedure. So the case becomes a medical MDC 09 case. Refinement, is there an MCC present? No. COPD is not an MCC. The MSDRG assignment for this case then becomes MSDRG 603, cellulitis without MCC. The CC-MCC exclusion lists, they change every year. Remember the Federal Register. They update those lists every year. They often take things off, and occasionally they'll put a couple of things on. So you have to know what's on the CC-MCC exclusion list every year. They will tell you also when there's a principal diagnosis type change too. But make sure that you update yourself on an annual basis with what's on CCs and MCCs, because what's on a CC-MCC list changes, and what's on an exclusion list changes. So notice there's a difference there. This is invalid coding and data abstraction. If you end up in MSDRG 998 or 999, that is not good. There's something going on there that you really need to take to a more expert coder or a coding supervisor to take a look at, because very, very, very rarely is it true. 998 is principal diagnosis is invalid as discharge diagnosis, or the principal diagnosis is not specific enough for MSDRG assignment. That screams bad documentation. That screams lack of documentation. Just not a good situation. MSDRG 999 means ungroupable. That means there's something invalid going on in terms of diagnosis code, age, sex, or discharge status code. And again, both of those need very close scrutiny by an experienced coder or a coding supervisor. So what else is included in the inpatient prospective payment system provisions? Well, high cost outlier cases. A cost outlier is when the hospital's cost for a case, the charges adjusted to cost, exceed the threshold limit established for that fiscal year. And you can apply to have the case considered a high cost outlier case. Doesn't mean that the government's going to agree with you or that they will give you that additional payment amount equal to 80% of the difference between the hospital's entire cost for the stay and the DRG payment plus threshold amount. So there's a slim chance you might get outlier payment, but I wouldn't bank on it from past experience. There's also new medical services and technologies where they ensure new and innovative services and technologies are provided to Medicare beneficiaries and provide additional payment. Again, it's tricky to get those, and typically you've got to have prior authorization and lots of documentation to get it. But if you do get it, it's full DRG payment plus up to 50% of the cost of the technology or service. And the cost limit is established for each service or technology, and this is also published in the Federal Register. So if you want to know about the cost outlier and the new medical services and technologies, what it's going to be for that fiscal year, go to the Federal Register and look at the final rule. So this just gives you an example of new technology for 2021. Jakafi, ruxolitinib, Jakafi is used to treat adults with polycythemia vera who have already taken hydroxyurea and it did not work well enough, or they could not tolerate it. It's not a chemotherapy. It's a treatment that works to help keep the production of blood cells under control. The maximum add-on amount is $3,977.06. The PCS code, and that's the inpatient procedure code that you would assign for introduction of ruxolitinib into the mouth and pharynx. External approach, new technology group 5, is XW0DXT5, and that is used to activate the add-on payment if you've got everything else in line that you had to have in line approved before you gave the patient that medication. All right, transfer cases. This is where it gets tricky and why you need to have the correct discharge disposition on every single case before you bill it. Transfer cases, when you're transferring between two inpatient prospective payment system hospitals for acute care, or when you're transferring from an inpatient prospective payment hospital to a hospital or hospital unit that's excluded from IPPS, meaning non-acute care, you fall into what's called transfer cases, and they have different methodologies for that. There's also a post-acute care transfer policy or PACT for designated MSDRGs. The type 1 transfer methodology is applied rather than the type 2. That ensures an incentive is not created for facilities to discharge patients early to reduce costs while still receiving the full MSDRG payment. And you'll see this in your book as you read through the chapter. It'll give you the examples. Oh, here's one. Type 1, transferring hospital receives per diem amount, which is the MSDRG rate, geometric length of stay, double per diem for first day, single per diem each day thereafter. And then the receiving acute care hospital is provided the full IPPS payment. Type 2, and this goes back up here to type 2, where you're going from an IPPS hospital to a non-IPPS hospital or unit. The transferring hospital gets the full IPPS payment. The receiving hospital or unit receives full PPS payment applicable to the setting. So if it's long-term care, SNF, home health, they get paid based on the setting, not the IPPS payment. Base payment rate, per admission amount that's adjusted for each hospital. It's published each year in the IPPS final rule, divided into 2 parts. That base payment rate includes labor-related share and non-labor share. The base rate is adjusted with hospital-specific values, including wage index, cost of living adjustment, disproportionate share, hospital, which is also known as DISH, in case you're curious about that, and indirect medical education. If you are at a healthcare facility that does medical education, you may have all of these included in your base rate. It just depends on the facility. And the facility's CFO is notified what their base rate will be every year. So this goes into wage index, cost of living adjustment or COLA, and DISH, disproportionate share, hospital status, and indirect medical education. I'm going to encourage you to look to your textbook and go through that there, and it'll explain all of those. So, simply put, the MSDRG rate, relative weight, times the hospital-specific adjusted base rate payment rate plus provision payments is going to equal reimbursement. And again, you'll want to go and look at your textbook for examples 5.7 and 5.8. The hospital value-based purchasing program includes withholding a portion of facility payments and then redistributing them based on the facility's performance for the designated quality measures. CMS reduces the MSDRG base payment amounts by 2% for all providers and then redistributes the withhold based on facility total performance score. The total performance score is a measure of the facility's overall performance for the clinical domain, quality measures, and other requirements in the value-based purchasing program. So essentially what happens is the government every year holds back 2% from every facility in their base payment amount. At the end of the year, when all the dust settles and all the reports are in, if you as a facility have met all of their requirements for the value-based purchasing program, you will get your 2% back. If you have failed, your 2% is gone. And in some cases, in some areas, they will allow for more than 2%, but it's usually 2%. And in many facilities, 2% can be $1 to $2 to $3 million. So it's nothing, and it can be hundreds of thousands of dollars for small hospitals. So it's nothing to sniff at. It's something to take very seriously. I have seen hospitals who have failed to take this seriously and have lost money because of it. So there are 4 domains when it comes to value-based purchasing. There is clinical outcomes, person and community engagement, safety, and efficiency and cost reduction. There's a performance achievement component where the facility's performance is compared to all other facilities, and then there's performance improvement component where the facility's current performance is compared to their baseline performance. Have you ever heard of HACs, Hospital Acquired Conditions, or POA, Present on Admission Indicator Program? These two things came out of CMS because CMS felt that if a patient acquired a significant condition at the hospital while admitted, that the hospital could have or should have prevented, and it extended the length of stay and increased the MSDRG, that they shouldn't have to pay for it. And so the way that they could figure out whether or not it was something acquired in the hospital is to have what's called a present on admission indicator for every inpatient hospital diagnosis. So if you work for a hospital, an inpatient hospital, and you're coding every diagnosis that you put on an inpatient claim, you have to have a present on admission indicator. It has to say whether or not it was present on admission, not present on admission, unknown, unable to determine, those types of things. Hopefully it's always present on admission, but there are things that do come up. And so that's how this all came into being, is that Medicare basically said that if there is a preventable condition that the patient acquires, doesn't have an admission, while they're hospitalized, that they will not pay it at whatever MSDRG level it's billed at. They will pay it at the lower severity. And the facilities who have HAC scores in the lowest performing quartile will have payments reduced by 1% for all encounters. And there are some examples here that they've listed for you of health care acquired conditions like catheter associated UTIs, central line associated bloodstream infections, so CODIs and CLABSIs, C. diff infections, surgical site infections after colon or abdominal hysterectomies, colon surgeries or abdominal hysterectomies, MRSA, patients who acquire a MRSA infection, or bacteremia. They also instituted what's called Hospital Readmission Reduction Program. This is where the patient returns to the hospital within 30 days of discharge from the original admission, and the admission is not a planned readmission. And usually they're looking to see, is it something that is associated with that first admission. So let's say that you have a patient who has some type of infection. And, well, actually, let me back up. Let's say that you have a patient who comes in for a planned hip replacement. And they go home, and within 30 days, they're readmitted, but this time they're readmitted for a surgical site infection where that hip replacement was done. The hospitals, CMS is saying that when it's something like that, that's something that should have been preventable. And so they can have up to a 3% reduction in their base MSDRG operating amount reduced for all admissions during the applicable payment year if their hospital readmission rate is too high. So every time there's a patient who is readmitted within 30 days of discharge, someone is always looking at those cases to figure out why, and are they going to be in the exclusions, or are they going to have to be reported, and what could have been done to prevent those. So this gives you an example of some that they're looking at are AMI, heart failure, pneumonia, COPD, total hip and total knee replacements, and CABG surgeries. And this just goes back to our patient Malachi. They're going to give you an example with him and talk you through how the reimbursement is. And now they're going to talk about Olivia, our second patient here. And you can go through there and they'll show you how they calculated the reimbursement. All right, that is it for for Chapter 5. Thank you so much for hanging in there. I know it was a long lecture. Sorry about that, but there was a lot of material to cover. Hope you have a great week, and I'll